somebody asked last time about dementia with Lewy bodies. So today I thought that's what what we would talk about. So I'm just going to put on this presentation, and feel free to chip in at any time with questions. Okay. Okay. Can you all see my slides?
Yes, please.
Yep. Okay. Brilliant. So dementia with Lewy bodies. Dementia with Lewy bodies is the dementia that Robin Williams passed away with. It comes under the umbrella of dementia. We've spoken before about dementia being the umbrella term for hundreds of different diseases and syndromes that affect the brain's cognitive ability to work. So there are two types of dementia with Lewy bodies. There's dementia with Lewy bodies, and then there's Parkinson's disease dementia. So they are very, very similar, but there is a difference. So if somebody showed symptoms of Parkinson's and then the symptoms of dementia, it would be Parkinson's disease dementia. Okay, so there's a fantastic doctor who explains this wonderfully. So I'm going to show you her presentation in a moment. So the difficulties people experience dementia with Lewy bodies is the thinking process. Okay, understanding the world around them, can misinterpret situations. Their visual perception of what they're seeing can be affected. Their spatial awareness, they might go to put something on the table, but actually miss the table. Sometimes we have people with dementia Lewy bodies that put themselves on the floor because they feel safer. Sometimes it feels like the floor is moving. The only way I can describe it really is if you've ever got a little bit tipsy and it feels like you're on a boat, things are moving. It could look like things are moving. So some people with dementia with Lewy bodies will put themselves on the floor. They feel safer there. Memory problems like most dementias. Yeah. The most recent memories, the um, what we did yesterday and the day before. So the short-term memory is affected first before the long-term memory. And people also experience sleep problems. Now, with dementia Lewy body, people can experience quite horrific night terrors. They're not nightmares, they're night terrors. People can wake up screaming and sweating profusely and are frightened to go to sleep, or some people have trouble actually going to sleep anyway. They experience insomnia. Okay, next one. Oops. There's dementia with Lewy bodies. Parkinson's disease dementia is they have difficulty in movement. Um, they their muscles could be quite stiff, um, and their coordination can be affected. And as you might see with people with Parkinson's disease, they have the tremor, and they do a movement what we call pill rolling. So it's kind of like rubbing their forefingers and thumbs together when we call it rolling, and they get a little tremor, and they shuffle when they're walking, so they're a high risk of falls. They also experience rigidity, and they can be as stiff as a plank. So that's why it's really important that people get their medication on time, and the rigidity can be really quite painful. There is a slowness in their speech, and they develop what we call a mask-like expression. So as the Parkinson's disease progresses, they lose the ability to show expression on their face. They can't smile or frown. It's just like a mask. And they often can dribble, and their swallowing is affected. So the high risk of choking. So they're the differences between the two types of dementia with Lewy bodies. I'm gonna now play this lady. It's about half an hour, but it's a really good video of this doctor explaining the two difference of these dementias. And then, if there's any questions at the end, we could talk about it, or if there's anything else that you guys would like to talk about. But
I just asked a quick question?
Yeah, of
Is
course
that
you
all right?
can. Yeah.
Is it because my father's been diagnosed with Lewy body, and he has some of the classic symptoms of both. So, is it possible to have sort of overlap? I mean, I'm sure it is, but yeah.
Yeah,
Okay.
definitely. And the other thing about dementia and Lewy bodies is they can have periods where they're really lucid.
Yeah.
And they know exactly what's going on.
It's
And
so
I think,
frustrating.
and it's sad because you know that they're going to go back into their confused state. And also what happens, and it causes a lot of frustration with families, especially in the beginning when they don't understand what's going on, is that somebody with dementia Lewy bodies can one day be doing things really quite well, getting themselves dressed, wash their face, and then the next day they can't. And then people think they're putting it on. You can do it. You done it yesterday or you done it this morning. Why are you not doing it now? But they really can't. So that could cause a lot of frustration in the early days because families think that they're just playing up, being awkward when they're not. They really can't help it. So that their level of abilities does fluctuate quite a lot.
Does that relate to, Anne-Marie, does that relate to what Wendy was saying last month about it being akin to a string of lights, and sometimes they flicker and come back on, and sometimes they go for good? Yeah.
I know. I describe it as a faulty kettle. You've got that kettle and it won't boil, but if you wiggle that wire, it'll boil. And then another day you can wiggle it as much as you like and it won't boil. But yeah, absolutely. Poor Wendy's lights have been going out a lot over the last couple of weeks or so, bless her. Which is really quite upsetting. I think we got Wendy on a good day. It's really quite sad. Yeah. So yeah, exactly what you said, Towels, is that it does fluctuate. The connections happen, and then they go. I remember a gentleman, and it was so sad. He was getting really distressed, and as we worked out, he wanted to go to the toilet, and we were trying to coax him to the bathroom, and he was shouting, getting really cross with us because he thought we were, in his mind, interfering. He wanted to go to the toilet, he wanted to find it, but we were getting in the way, where in fact we were trying to guide him. Anyway, we did get into the toilet, and we sat him down, was reassuring him, and bless his heart, he started crying because that connection suddenly happened. And he said, "I'm so sorry, girls. He said, I'm so sorry. I wouldn't hurt you for the world." He said, "I can see myself doing it, but I just can't stop." He said, I wouldn't hurt you. I wouldn't shout at you. I'm so, so sorry." And we were reassuring him, hugging him, saying, "It's okay. It's okay." And then about 5 minutes later, he was back in his confused world. And that upset me, really, because I thought, how sad for that poor man. Okay. Any other questions before I put the video on? No?
So one for me. I mean,
Yeah.
mum's got dementia with Lewy bodies, and she's had a couple of falls. For the insomnia, they were giving her quite a lot of sedatives, which has caused problems with her now falling. So she had a fall and a bleed on the brain before she was actually moved to Ethelred. So this is not something from XLK. This was prior. I'm just a bit concerned that that was the case, that there wasn't the care taken, that this insomnia is obviously part of the disease, but obviously that ability with spatial awareness and things as well has not helped, because she's then been sedated for her sleep, and then the spatial awareness has kicked in and she's had falls. So I'm just wondering if that's a regular thing that people come up against, where sedatives are given and then that can probably extrapolate the situation.
Yeah, it is. And what we try and look at is keeping that person active during the day. Yeah, keeping them busy.
I have to say the people at Ethelred have been absolutely amazing. The difference in mum since she's been there has been fantastic.
Sedative medication is always our last resort, and always should be the last resort. The time where we would give it if the person was at risk of harming themselves or others. But if somebody is sort of up, not able to sleep, not up at night, we would try during the day, keep them as active as possible. Bit of fresh air, hot chocolate or Horlicks before bedtime. Sometimes it's making that bedtime routine of tucking them in, maybe a kiss on the forehead, night night. Do you want your lamp on? Do you want a bit of music on? A bit of smelly, you know, lavender, whatever. So making a sort of a bit of a routine of it. However, we do have some people that don't go to bed. They prefer to sleep in an armchair with their feet raised. And sometimes we do have people who have done that day-night reversal because in their dementia world, they're still working. So they used to work nights.
We were
so,
there at one point.
Yeah, so as it starts getting dusk.
That's exactly what happened, really.
That's the cue to go to work.
As she was progressing, she was very manic and quite aggressive as well. So, I mean, we both had, you know,
bumps and bruises
and hairs and in that period. So it was very sort of combative, but she was seeing totally different things.
She's hallucinating and
was very manic. So it just got, we basically, we really needed help, and we just, we were literally getting a beating most of the time. So it became difficult.
With dementia Lewy bodies, people do hallucinate. They see people, they see animals, they see children, and it could be really quite frightening. And I the other night, I wasn't expecting a delivery from the Amazon man. It was like 8 o'clock at night, and I was in my pajamas, and the door went, and I thought, well, I'm not answering that because I don't know who it is. I wasn't going to go out there. I was on my own. You know, my husband had gone to work, and then all of a sudden there was this man peering through the window. And I was really scared. Lucky enough, I was talking to my neighbour. He said, "Do you want me to come round?" I went, "Oh yeah, yes, please." But it made me think then, but how does it feel to be living with the dementia? You're hallucinating, seeing a strange face, and so I would scream, and then like if I've got somebody, even though they're my relative, but I don't recognise them at that point, how frightening that can be.
So with mum, one of my questions I posed online beforehand was about how best to help mum cope with that kind of situation with the Lewy bodies. I mean, we've got her a radio for a room, just low on classic FM or something. We've got some lavender smellies in there to try and do it. So doing that is the right kind of thing, just to try and set that relaxation. Okay.
Yeah, absolutely. And sometimes what you can do is, because with the best will in the world, we're expecting people with dementia to live with 30, 40 other people. At home, there's only about 2, 3, 4 of us, isn't it? But we're expecting people to live with all these other people. And it could be quite noisy. And there could be noises that you don't quite understand. So what also does help for some people is noise cancelling headphones. But what you could put in is those little memory cards with favourite music. So they can listen.
That's a great idea.
Listen to that rather than hear all the other noises. But it's going to be music that she likes. It might be even, and I've just bought a couple for myself. Haven't listened to them yet, but like guided meditations.
Yeah.
So you're sitting there and then somebody's talking to you, saying whatever, walking through the tulips or whatever it is. But sometimes that helps. It takes you away. Or what do you call them? Books.
Yeah.
Audio books. That's the word. Audio books. Yeah. So they're things that might help.
That's a great idea, because she is triggered a lot by noise. She really struggles with loud noises. So no, thank you. That's a great idea.
And don't forget TV. Sometimes people with dementia think what's on telly is real. So sometimes they don't understand it's on television. So that could be quite frightening as well.
Sorry, what were those headphones that you mentioned? What are they? Just standard?
You get them from Argos or Amazon. But they're, the ones that go over the ears, so that you can't hear what's going on around there, and then you get your memory stick down. You know what you call it, your little memory card thing.
Yeah.
A USB.
Yeah, or I don't know. You know the little cards you get, SD cards.
Yeah, memory cards.
Oh right, yeah.
Download favourite music onto that, and then pop it in the headphones.
Oh, I see. So I didn't even know there was such a thing. Okay.
Yeah, don't get Wi-Fi ones. Don't get Wi-Fi because you haven't got nothing to do with the Wi-Fi. But yeah, just little memory cards. I mean, I've got a bit of film of a lady, one of our ladies, who used to just scream and scream and scream, and she used to hallucinate, and she got Charles Bonnet syndrome, which is horrible. It's where she lost her eyesight, and we did that with her, and she has been so settled and contented. She's now not on the dementia community. She's now on the nursing. Because if you can imagine, if you're hallucinating and hearing strange noises, and it could be just so frightening.
Yeah.
You can't say. Any more questions?
I just wanted to say to Elle, make sure you get the ones that are noise cancelling, because as a young man on the train explained to me the other day, they don't all cancel the outside noises. So noise cancelling are also the kind of ones that someone on the autistic spectrum might use to dull out.
Yes. Okay, thank you. That's really, really helpful.
And the over-ear ones are usually better, aren't they, rather than the in-ears, because they.
Oh gosh,
I
can't imagine my dad trying to sort that one out. No.
And they can be painful. Them ones that go in ears. I can't do them. Okie dokie. Right then. Next one. Here we go. Right. Shout if you can't hear her. Okay.
Hi, everyone. I'm Dr. Jory Fleischer from Rush University in Chicago, and it's my pleasure to be talking to you today about Lewy body dementia, or LBD. We'll cover the who, what, why, and what's next. So hopefully you can all see my slides, and it might seem strange, why are we talking about Parkinson's if we're talking about Lewy body dementia? And I hope to make that clear. And often these entities are kind of enmeshed, and it's hard to figure out, wait a minute, is this Parkinson's? Is this Lewy body? What does this all mean? So we're going to try to sort that out today so that you can understand what's going on, and then what you need to do, what to expect, what to do to move forward. So Parkinson's. So in 1817, Dr. James Parkinson described essentially 6 patients, and he published this essay called The Essay on the Shaking Palsy that described the key features in what we now call Parkinson's disease: slowness of movement, or bradykinesia, movement that's slow, that's small, that gets smaller as it goes. We look for taps and they get tiny. Stooped posture, facial masking, so diminished facial expression, a tremor at rest, often in the hands, sometimes in the jaw or in the legs, stiffness of the muscles, and a tendency to shuffle while walking, or to get stuck while walking, or to race ahead, almost like the top half of the body is going at a different speed than the bottom half of the body. And so this became known as what we call today as Parkinson's disease. And then in 1912, Dr. Lewy was the first to describe what are called inclusion bodies, or sort of these glommed up balls of protein inside of a brain cell that would later be known as Lewy bodies. So on the slides, you see that there's sort of this highlighted, see if you can see this, so there's a highlighted pink, kind of darker pink in the middle, halo of light pink on the outside. And that little ball, that sort of gumball looking thing in the middle of a brain cell, that is a Lewy body. So to try to figure out, does someone have Parkinson's disease? Do they have dementia with Lewy bodies? Where are they in this scheme? We sort of think about this Venn diagram of Parkinsonism. So I like to think about this as Parkinsonism is a category, like headache. Migraine is a type of headache. So Parkinson's disease is a type of Parkinsonism. Dementia with Lewy bodies is a type of Parkinsonism. So how do we even figure out if someone is inside this box of Parkinsonism? So we look for those cardinal features, the same things that Dr. Parkinson's described. So bradykinesia, or slowness of movement, and at least one of the following things: rigidity, that's stiffness of the muscles, a tremor, especially at rest, and postural instability, or that tendency to fall, the tendency to be very stooped over. We look for those things. And if you have that bradykinesia, the slowness, and at least one of those other things, then we can say you have Parkinsonism. So now you're in this box of Parkinsonism. And the things that support a diagnosis of Parkinson's disease are unilateral onset, so symptoms that start on one side of the body, and while they may spread over time, always tend to be worst on the side where they started. Typically, that's a person's dominant side, and it tends to stay asymmetric. And then because this is a disease of dopamine deficiency, the cells that make dopamine are dying off before they should. And so one of the things that helps us build confidence in the diagnosis is if we give you dopamine back, do the symptoms get better? And so that term is levodopa responsiveness. Levodopa is the medicine equivalent of dopamine. And if you continue to respond, if the slowness and the stiffness especially continue to get better in response to taking the levodopa, and especially that goes on for more than 5 years, then that says that you're pretty clearly on the path of Parkinson's disease. If down the line, many years in, people develop levodopa-induced dyskinesia, so the sort of extra fidgety, wiggly, dancey movements as the medicine is peaking in your system, that's also consistent with Parkinson's disease. And someone who has symptoms that go on for at least 10 years, that's also consistent with Parkinson's disease. Except we can't know that at the onset, right? Some of the other things that help us be more sure that we're facing someone with Parkinson's are olfactory loss or loss of sense of smell. And this was part of Parkinson's long before COVID hit the scene. REM sleep behavior disorder, which is acting out a person's dreams during sleep. So kicking, thrashing, screaming during sleep, almost like the switch to turn off the muscles, doesn't get flipped when someone with Parkinson's is dreaming. And then constipation, which can happen years or decades before any slowness, stiffness, tremor. One thing to know is that about 30% of people with Parkinson's will never have a resting tremor. And so that alone doesn't mean that they have atypical Parkinson's. But what can be atypical for Parkinson's is to see an early decline in cognition or memory and thinking and fluctuations in cognition early in the course of the disease. To see early, recurrent, complex visual hallucinations. And we'll talk more about hallucinations in a minute, but hallucinations are a phenomenon, a sensory experience that there isn't a reality for. So you're seeing something that isn't really there. Levodopa resistant akinetic rigid syndrome. So what does that mean? Taking those words apart, the akinetic rigid means really slow, really stiff symptoms, but that doesn't get better when the person is on levodopa. So in a typical Parkinson's setting, someone who's really stiff, really slow should get better with levodopa. In the case of some of these other atypical forms, or if someone is given levodopa and those symptoms don't get better, we need to kind of think, are they really in the center of that diagram? Is this really Parkinson's, or could this be one of the related conditions? And if someone starts to fall within the first 3 years of their symptoms, that makes us think about those other things in the Venn diagram. So how do we make this diagnosis? Those are the things that we consider. Those are the things that we look for. But what's the difference between dementia with Lewy bodies and Parkinson's disease, dementia, and then Lewy body dementia? So bear with me for a second. I think about this as a chicken and egg problem under an umbrella. Okay, so Lewy body dementia, or LBD, is the umbrella. It's an umbrella term that describes 2 problems in the brain where synuclein, a protein, goes wrong. So we call those synucleinopathies. So Lewy body dementia describes 2 synucleinopathies: dementia with Lewy bodies and Parkinson's disease dementia. So there are lots of ongoing arguments and debates about the semantics of lumping these together or separating them apart, but it becomes a bit of a which comes first, the chicken or the egg argument. And this really hinges on 2 groups of symptoms and 1 key timeline. So if Parkinsonism, if the slowness of movement, the tremor, the stiffness, if that all happens first, and at least a year later, but typically several years, 5, 10 years later, a person starts to have changes in their memory, their thinking, they start to have hallucinations. That's someone who has Parkinson's disease dementia. So the Parkinson's disease comes first, the dementia comes later. So we call that PDD, Parkinson's disease dementia. If, on the other hand, the dementia comes first, or the dementia and Parkinsonism start around the same time, within a year of each other, so this 1 year rule, the dementia and the Parkinson's happen together, or dementia happens first and then Parkinson's comes a year later, that we call dementia with Lewy bodies. So what's really going on? Why is this? So in the brain, we can look at this because it really has to do with those Lewy bodies, those pink things that I showed you on the slide. So where those Lewy bodies are starting to develop in the brain and along what time frame. And so there's something called the Brock hypothesis. Brock is a pathologist, and he looked at the brain of people with various stages of Parkinson's disease for various points in time, and people with Lewy body dementia. And what he found is we see those same Lewy bodies. It's like someone placed those in the brain. But in Parkinson's disease, it's almost like the Lewy bodies sort of got a hiker's map and they follow a trail. The Lewy bodies over time start to develop deep in the brainstem, and over time they gradually spread upwards through the brain, forwards into the frontal lobes of the brain, and sort of around the back through the gray matter. And so we see the motor symptoms first, the constipation, the sensory, the smell changes first and early in Parkinson's disease, because that's what's going on in the brainstem and sort of the forward areas of the brain. And slowly over time, the Lewy bodies spread towards the back of the brain, and that's where we get the hallucinations and some of the other cognitive changes. On the flip side, instead of following the hiker's trail and sort of going along one path, in dementia with Lewy bodies, it's almost like someone took a grenade full of Lewy bodies and set it off. And we see those Lewy bodies in cells all over the brain early on. So you get some of the Parkinson's features, you get the smell changes, you can get the sleep changes, but you also get the hallucinations, you also get the memory and thinking changes, because those Lewy bodies are everywhere, glomming up the system, messing things up. So to make a diagnosis of definite dementia with Lewy bodies or definite Parkinson's disease dementia, the only way that we are 100% accurate is to look at a person's brain under a microscope after they've died. So what do we do before that to get as close to a diagnosis as possible? And we can get pretty close. We can get into the 90% certainty. We think about probable dementia with Lewy bodies or possible. So to say someone has probable dementia with Lewy bodies, they have to have a few things. So the essential feature is that they have to have dementia, and dementia is defined as a progressive cognitive decline of sufficient magnitude that it interferes with their normal social or occupational functions or with usual daily activities. This isn't just the forgetting a name or something at the tip of a tongue for a bit of time. This is that it's the cognitive changes are really getting in the way of daily activities. So you have to have dementia to say you have dementia with Lewy bodies. And then you have to have at least 2 core clinical features. That includes cognitive fluctuations, which means that there are big variations in attention and alertness throughout the course of a day. Someone could be having a great conversation with you, talking as if this was them 10 years ago. They're spot on, talking about their job, recalling details of current events, and almost like someone flips a switch, they go glazed out of it, very confused, very hard to have a conversation. Nothing clearly led to that kind of switch flipping, and you can't really predict when it's going to switch back. It will, but there's nothing you can kind of do to snap them out of it. It's almost like they're on and then they're off, and that's really prominent. So those are cognitive fluctuations. The visual hallucinations, which I've mentioned, we'll talk about a little bit more. REM sleep behavior disorder, so acting out dreams during sleep. The person is asleep, but they're kicking, they're thrashing. If they're dreaming about basketball, they might be laying in bed and going like this. And then Parkinsonism. So I said that they have to have dementia and then 2 of those core clinical features. So there are people with dementia with Lewy bodies who have dementia and those cognitive fluctuations and maybe the visual hallucinations, maybe the REM behavior disorder, but don't have Parkinsonism. They might develop it down the line, but they don't need to have that at the beginning. The other option to meet these criteria is to have dementia one core clinical feature and one of these indicative biomarkers. So an abnormal SPECT scan or PET DAT scan, an abnormal MIBG scan, which isn't usually done in clinical practice, or a sleep study that confirms REM sleep behavior disorder. So not just based on symptoms and description, but they see it on a sleep study. So I mentioned that there are some other symptoms. What are they and what do we do? So sleep disorders are very common in people with either Parkinson's disease dementia or dementia with Lewy bodies. And for the rest of the talk, I'm just going to refer to all of these. They fall under that same umbrella. They're the chicken and the egg sitting under the umbrella of Lewy body dementia, or LBD. So sleep disorders are common in LBD. People can have insomnia. They can have trouble falling asleep, trouble staying asleep, waking up too early in the morning and have trouble getting back to sleep. And they can have that REM behavior disorder. Usually that's more disruptive to the bed partner than the person themselves. We want to make sure that there isn't any untreated depression, anxiety, restless leg syndrome, stiffness or cramping of the muscles called dystonia, any pain. We want to see if someone is waking up in the middle of the night to go to the bathroom. And there's a difference between waking because your bladder is waking you up and you need to pee versus waking up for some other reason. You might as well go to the bathroom because you're up already. If your bladder is waking you up to pee, well then we should treat the bladder. We should see if there are ways that we can get you to stay asleep longer by treating the bladder symptoms. Sometimes sleep apnea is at play. It's more common in people with these disorders, and that's very treatable. Or nightmares. And if we've treated all those other things, if we've sort of knocked those off the list, then there are other things that we can use to try to treat insomnia. So this includes things like melatonin, both regular melatonin, sort of immediate release that helps you fall asleep, and then there's timed release, which helps you stay asleep for longer, and other medications which are used off-label in Lewy body dementia, things like mirtazapine or trazodone. Especially important is sleep hygiene education for the patient and the caregiver. If you've got TVs going on in the room, if you're using a screen before bedtime, if you wake up in the middle of the night and you pull out your phone or you're reading or you're doing other things that keep you stimulated, it's going to be hard to fall back asleep. So really trying to make sure that you have a safe, calm, sleep-friendly environment. If someone has REM behavior disorder, we can try treating that with melatonin, or we can use low-dose clonazepam. Those are common things. We also want to look at home safety. So if someone is kicking and thrashing and is at risk of falling out of bed because of their REM behavior disorder, putting a really thin yoga mat or a gym mat around the bed, something that they won't trip on when getting in and out of the bed, but if they fall out of the bed, they've got a little bit of cushion there. Thinking about bed rails, padding, bed alarms can be helpful, and moving any nightstands, any furniture with sharp corners out of the way of the bed, or cushioning those corners. So you can get childproofing supplies and put those on corners, or you can go to your local hardware store, pick up some ugly, cheap pipe insulation, but it works wonders. Bend it around the corner of those sharp corners of furniture, and this way when someone is thrashing out of bed, most often they will hit the side of their head, they'll hit right here, and those are nasty bruises. So many people are surprised to hear that the #1 predictor of quality of life in Parkinson's and Lewy body dementia tends to be depression. Not the motor symptoms, not the hallucinations, it's depression. This has a 30 to 40% cumulative prevalence, which means if we look at everyone with the disease over time, for all of the time that you have this condition, 30 to 40% of people, if not more, will develop depression. And it's not just a response to, well, you'd be depressed too if you had this diagnosis. Yes, that's called an adjustment disorder. Everyone is allowed to have that response and that reaction for some period of time after getting a life-changing diagnosis. But the depression that I'm talking about is a chemical change that's part of this condition, part of Lewy body dementia, because there are changes not only in dopamine, which affect movement, but in serotonin and norepinephrine. And those are chemicals that regulate mood and anxiety. So there are a lot of things that we can do to treat this, and it is imperative that we treat it. Because if we don't treat this, we wind up not treating the other things. We can prescribe a beautiful medication regimen for the slowness or the stiffness or the hallucinations, but if a person is too depressed and unmotivated to take those treatments, to do those things, well then what does it matter? So we can start with non-medication options, which include social involvement, support groups, talking with a counselor, supportive psychotherapy, Exercise is really beneficial for mood. Cognitive behavioral therapy is really beneficial. But if those are not enough, especially after 12 weeks of putting in a really good hard try with therapy, if we're not seeing an improvement, then it is time to move to medication, not because it's a failure on someone's part, but because this is a chemical change. So we need to address it with chemicals as well as everything else. And the best way to treat depression in people with Lewy body dementia is the same way that we treat depression in everyone else. So the first line medications are things like SSRIs, that's your standard fluoxetine or Prozac or Lexapro or things like that. And then cousin drugs like SNRIs, much more so than some of the older school medications. Anxiety is very common in people with LBD. This can be something that's there for years before they get the diagnosis, but it's something that's different compared to how anxious they were decades ago. Sorry for the sounds of the subway. And so this can show up as a loss of confidence, a fear of social occasions, a fear of public speaking, a generalized anxiety state, or really specific things. A lot of anxiety around appointments, a lot of anxiety around driving and traffic and parking. And so the need to go, leave 3 hours early to get to someplace. And just like depression, this is a chemical change related to the underlying disease. And so we can try to treat it with non-medication options. We can also use medication options to add in. So I mentioned dementia, which is inherent to dementia with Lewy bodies, Parkinson's disease dementia, and the overarching Lewy body dementia. So this isn't the same as Alzheimer's disease. Alzheimer's, in that case, people have very frequent short-term memory issues, sort of forgetting the conversations that just happened, sometimes forgetting who the people are that are around them. That's not the kind of dementia that happens in LBD. So in LBD, we see those cognitive fluctuations, these big sweeping changes from moment to another moment, where someone can be spot on one moment and really kind of out of it the next moment, and then come back. Visual hallucinations are very, very common, although we can sometimes see auditory hallucinations. People hear things that aren't there. Depression is very common, and then sleep disturbances. These are some things that really distinguish this from Alzheimer's, and in particular, visuospatial dysfunction, getting very turned around, navigating familiar and unfamiliar spaces, putting things, instead of putting the coffee cup on the counter, putting the coffee cup hanging halfway off the edge of the counter. Because to the person with Lewy body, it looks like their brain is telling them it's on the counter. Their depth perception can be very skewed. They may, reach and put something in the wrong drawer. It's not a totally off the wall place to put something, but they put the silverware into the dish drawer or the towel drawer, even though those haven't changed in years and years. It's just slightly off, definitely different. So I think that this is a common misconception, but because someone has dementia does not mean that they're now immune to depression and anxiety, especially in the case of Lewy body dementia. People can have insight into what's going on. And so it shouldn't be surprising to us that then they can still have depression, they can still have anxiety, because those are all still chemical changes going on. So the hallucinations that I mentioned, people can have what are called illusions, where they see something out of the corner of their eye, but they mistake it for something else. So I see that chair in the background, and for a split second, I think that it's a person, and I turn and realize, nope, it's a chair. Then there can be sensory illusions or passage hallucinations, a feeling of someone walking up behind you, sensing a presence when no one is there. And over time, this can evolve to visual hallucinations. So evolving from something simple, non-threatening, maybe a floater, maybe a shape in space, to a little cat in a corner, a little mouse, a bird outside the window, kids playing in the front yard who aren't actually there, and evolving over time to more complex, constant, and sometimes frightening hallucinations. So if you see at the corner of the slide, there's a painting that was drawn by someone who has Lewy body dementia, sort of this very complex, kind of chaotic scene of hallucinations with multiple people involved. People can also have delusions in LBD. So people can have paranoia, either a generalized suspicion, sort of a generalized paranoia, or very specific about certain things or certain schemes. They can have delusional jealousy, which is the fixed belief, despite all evidence to the contrary, that their loved one, their partner, their spouse is cheating on them, even though there is no evidence of this. They can also have what are called Capgras syndrome or reduplicative paramnesias. What this is this delusion of an imposter, that a person, most often the people closest to them, so a wife, a husband, a spouse, an adult child, is an imposter, a perfect replica of their loved one. But they know deep down, no matter what you say, that you're not the real Bob, you're imposter Bob. And when is Bob coming home? Or it's, I want to go home. And you tell them, but you are home. No, I want to go home. And they don't necessarily mean a childhood home or someplace else. It's this deep-seated delusion that where they are is not really where they are. So that it's like the environment has been replaced down to the smallest detail with exact replicas, but something in them is telling them this isn't really their home, or this really isn't their loved one. And people will often not tell us these things until we really dig deep and ask. But if you feel like you're getting that, when is Bob coming home and you're Bob and going, what are you talking about? Let your doctors know. So there are a lot of different things that we do to treat Lewy body dementia. One of the first things that we do is we try to simplify the medication regimen to balance out motor and cognitive difficulties, because some of the meds that we use to treat the motor symptoms can worsen the cognitive difficulties and vice versa. So it is a tightrope balance, and it's a balance that changes over time as the disease progresses. So this is absolutely not a set it and forget it, the case of you've got high cholesterol, we put you on this cholesterol medicine and you stay on it for years. That's
What happened?
not the case in Lewy body dementia. It's sort of a constant reevaluation of what's going on, what is still of benefit, and what is of risk. You want to maintain a structured, familiar environment, maintain a regular sleep-wake cycle, a regular circadian rhythm. The worst possible thing, which has been the case for all of COVID, is to just sit at home, to just stare at the TV, to nap on and off so that the days kind of blend into nights, the nights blend into days, you shift your schedule and you start sleeping later and later and later, waking up later and later and later. That is really disruptive to anyone's brain, but especially to the brain of someone with dementia. And so we really need to protect against that and try to wake up at the same time each day, go to sleep at the same time each day, have structured activities, even if you're stuck at home. And then caregiver and family education and support is so critical. You are not alone. If your loved one thinks that you are cheating on them, you are not alone. This is not you. This is their disease, and there's help out there for it. So we have medications we can use to treat cognition. So we have medicines in the class of acetylcholinesterase inhibitors. These are things like rivastigmine or donepezil. Those go by Exelon and Aricept. These were developed for people with Alzheimer's dementia, but actually work well, if not better, in people with Lewy body dementia. But what well means is not that this turns symptoms around and we necessarily see improvement. We wish that that was the case. What well means is when we compare people receiving these drugs to people receiving a placebo, people on the drugs progress more slowly. So their symptoms still get worse over time, but worse on a slower pace than people who weren't taking the drugs at all. Sometimes we see improvement, but the expectation should be that we think of this almost like a vitamin. You take it every day, you don't expect to see something from it, but it's doing something underneath. For people with more severe, moderate to severe dementia, we can add on a medicine that works in a different way. So we sort of have a little of column A, a little of column B, and that's a medicine called memantine or Namenda. And again, the expectation should be this slows down how quickly things are worsening. To treat psychosis, meaning delusions and hallucinations, we don't tend to treat these unless these are really causing agitation, if they're getting in the way of care, if they're causing behavioral disturbances. If that's the case, we want to first look at the medication list with a really close eye, reduce things that are unnecessary, and then we can think about antipsychotic medications. So while the internet will tell you that antipsychotic medications are bad in people with Lewy body dementia and they can worsen the Parkinsonism, and that's true, antipsychotic medications are a family. And some cousins are better actors than some other cousins. And so we have options of things that we can use. For example, quetiapine is a medication that's a newer antipsychotic relatively, and we can use very, very low doses to treat some of the hallucinations and delusions without worsening Parkinsonism at very low doses. We can also use an older medication called clozapine, which works very well, does not worsen the Parkinsonism, but because of a rare but serious side effect, requires weekly blood draws to make sure that people aren't developing this rare but serious side effect. There's a newer drug on the market called pimavanserin. You may have seen some of the commercials for this. We don't really have long-term data yet. It's less sedating, which is the main side effect of quetiapine, but it may transiently worsen symptoms before they get better. What I wanted to make sure that you take away from this is that Lewy body dementia in both flavors does not change suddenly. This is a slowly progressive condition in the brain. It doesn't suddenly change from one day to the next. While the fluctuations, the cognition can kind of come and go, if you see a sudden change in mobility, loss of effect of the medications for mobility, increased freezing of gait, sudden increase in falls, sudden change in cognitive status that's different from kind of the day-to-day fluctuations, new or significantly worsened hallucinations or delusions. And most often we get the calls on our side that, this is happening Friday at 5:30, right before the weekend. The thing to know is it is almost always an infection or another reversible cause. So until we see a urine test that is negative, that is perfectly clean, it is a urinary tract infection until proven otherwise. Period. End of story. It is so commonly a urinary tract infection. UTI. Because people with Lewy body dementia frequently cannot say it burns when I pee, or I think it smells a little funny, or it's a different color than it used to be. The symptoms of a UTI in someone with LBD will classically show up as a change in their mobility or a change in their cognitive function or delusions or hallucinations. Other things that can prompt this are respiratory infections, pneumonia, things like COVID-19, other infectious causes. That includes dental infections, so always thinking about if a person is able to tell us that they're having tooth pain, infections of the feet, especially if someone is diabetic and could have ulcers, or pressure wounds that could cause an infection and go unnoticed. Constipation is so common, and when it's untreated can lead to a bowel obstruction. And so that's something we really need to watch out for and always consider if someone has a sudden change. Also, dehydration and any metabolic changes can lead to sudden changes in someone's behavior or mobility, medication errors, or new medication. So if nothing else has changed except for a recent refill of medication and the pill changed size or color, absolutely notify the doctor, notify the pharmacist. That could be the answer. There are lots of things that we can do once we've ruled out those sort of low-hanging fruit causes to try to treat gradual changes. And that includes taking away some of the medications that are sort of more risky on that tightrope. So the things that are maybe helpful for mobility, but much more likely to worsen memory and thinking. And also to consider low blood pressure as a potential cause of problems. So what's next? Get care, get answers, get active, get involved. So traditionally, the challenge for people with Lewy body dementia is because symptoms can show up in different ways, because there's so many different symptoms, and because different things come first, someone with Lewy body may present to their primary care doctor or internal medicine or family medicine doc, to a geriatrician, general neurologist, a movement disorders doc, a cognitive or behavioral neurologist, or maybe none of those, maybe seeing a physical therapist and someone goes, something's not quite right. And so all of those folks are important because they all can play a role in building your team to develop a care plan for someone with LBD. One of the things that I think is really important is to realize that there's a lot of stigma around the terms palliative care. People think palliative care means hospice, and those are different. Palliative care, sort of like headache, like Parkinsonism, palliative care is a much bigger category. Hospice is just a teeny tiny part of palliative care. But palliative care refers to a comprehensive focus on the person, and usually the person and their family. And it's symptom-focused care, focused on the goals of care for that individual person. And what's been looked at in the last several years are palliative care or palliative influence models for people with Parkinson's and Lewy body and related conditions. And what they've found is actually that pain, tiredness, depression, anxiety, drowsiness, stiffness, constipation, all of these things are the most common symptoms that people complain of in a palliative focused program. And that many of those are really amenable to treatment. Additionally, there are studies that have gone on, including from my team and others, looking at home visits. So teams of docs and nurses and social workers to come out to the home of people who can no longer come to the clinic. And we found that not only are people accepting of this and happy with this type of care, but actually that it can make a difference, that even though the disease continues to progress, quality of life doesn't necessarily need to slide down that same slope. And I think what this means isn't that everyone needs a home visiting team. It's not going to be feasible, but that staying connected to care, getting an interdisciplinary team approach. So not just a doctor, not just a nurse, not just a social worker, but all of the different folks bringing to bear their expertise for someone with Lewy body. So get answers to your questions. This doesn't mean Dr. Google, who doesn't have a great medical degree. Ask your doctor, ask other people living with Lewy body with a grain of salt. Go online, but go online well. So I highly recommend the Lewy Body Dementia Association. That's lbda.org. They have great resources. Also, Parkinson's Foundation is a lot bigger, has a lot more comprehensive resources, but if you dig, you can find stuff on Parkinson's disease dementia and all of these different symptoms that we can see in both dementia with Lewy bodies and Parkinson's disease dementia, all under the umbrella of Lewy body dementia. Finally, michaeljfox.org is a great website. It's a little bit more focused on research, a little bit more focused on Parkinson's disease specifically, but also plenty of resources there. Exercise, exercise, exercise. The only treatment, the only thing we have so far for any of these conditions that looks like it slows down progression is not a pill, is not an injection, it's not a vaccine, it's exercise. There are many reasons and many different studies that have shown that exercise changes the brain. It slows down how quickly things are getting worse. And the best exercise is the one that you'll do. So if you're not a runner, if you're not a biker, that's okay. Find something you can do and enjoy and stick with, and try to incorporate it into your daily activity. Start small, start low, go slow, gradually build up and add it in and make it part of the daily routine. Connect with others, get social, stay social, especially during these times of COVID. Online groups, FaceTiming, touching base with family, with friends, whether or not they have Lewy body, is really important. Do not just sit and stare at the TV. Volunteer, whether you're the person living with Lewy body dementia or you're a care partner. There are many studies that need people living with the disease and control participants, healthy participants. And also advocate. So if we want more answers, if we want more treatment, if we want a cure, all of us need to be out there clamoring for better, clamoring for more research. And the ways to do this are to volunteer in research studies, to write letters, call representatives, call senators at the state and national level to protect healthcare and research funding so that all of these things can move forward. So here is a screenshot in the slides from the Lewy Body Dementia Association. Lots of great resources on there. If you go to the tab that says research, you'll even get connected. It tells you about this biomarkers in Lewy body dementia, a clinical study by the DLB consortium. So many people say, I want a blood test. How do I know? Is there an imaging test that will tell me you have Lewy body dementia? And the answer is there isn't one yet, but many, many researchers are trying. And so this is a very big study going on at centers all across the United States. You can look up the center closest to you and see what participating in this study would look like for you. So with that, I want to remind you that Lewy body dementia, or LBD, is an umbrella term. Umbrella, chicken and egg. It includes both Parkinson's disease dementia and dementia with Lewy bodies. Lewy body dementia is a debilitating, multifaceted condition, but many symptoms are treatable. If there is a sudden change, think infection, infection, infection until proven otherwise. Get answers in the right places, get active, physically, socially, mentally. And if we want better treatments tomorrow, we need to take action today. So with that, thank you for taking this action and getting educated about Lewy body dementia, and be well.
Did you find that helpful?
Yes.
It was a lot to take in.
Yeah, it is. But I think she explains it quite clearly.
That's very good. Yeah.
That was so interesting. Just yeah. I did put a thing in the chat, but I don't know if it's working. Are we able to? I know this is recorded, but is it possible to get a copy of this recording? Because I've got family members who.
Yeah, absolutely.
Great.
Yeah, no problem at all.
Say there's lots of things that I recognise in the progression.
Oh, definitely.
Oh God, yeah, completely.
And UTIs.
So much like UTIs on, but especially the differences of obviously early condition where there's coming, in and out, and then just the progression and that jump. And paranoia and everything. I can kind of understand that whole spiral as it comes further on. So I thought it was brilliant.
Yeah, really good.
Good.
Yeah,
I mean, we have
lots to be recognised.
I know it's American, but it's the same for us. But we do have our own Lewy Body Association or Lewy Body Society here. June Brown, she's the patron of it. JuneBrown.cotton out of EastEnders, because her husband had dementia with Lewy bodies. She talks about her experience as well.
What's it called? Lewy Body Society.
Lewy Bodies. If you just put Lewy Body on the search, it'll come up. I can't remember if it's Lewy Body Association or Lewy Body Society. I think you find it is. Yeah.
I think when my father was having hallucinations, they were heading towards Lewy body, but obviously they can't actually diagnose. They think it's part Lewy body, part Alzheimer's, and it's just a mix of all different dementias.
And absolutely, Bill. People can have mixed dementia. I think, crikey, they've got one thing, they don't want another. But yeah.
But some of the drugs she was mentioning there with the rivastigmine and things like that,
Memantine and things. Yeah.
They've got Bill on those, and what they've also got is a sedative to make him sleep at night, because when he wasn't sleeping, his brain was naturally tired and his daytime was all over the place. So to try and get him to sleep during the dark hours gets him to have 6 hours of brain rest, and that's made a big difference. It's made a huge difference for him.
Can I, on that sedative note, is that something that the care home is able to administer? How does it work?
Well,
doctor prescribes it, but we only ask the doctor. We get the doctor to assess and we assess, but we only ask if the person is at risk of causing harm to themselves or to others, or it's causing them ill-being, not sleeping at night. Because
from my point of view, sorry to interrupt.
That's right.
Our mum was put on a sedative before she was moving into the home. Actually, she was she'd basically been manic and effectively was sectioned.
She was sectioned for a start.
My dad was too.
Because of that manic situation, like most, when you're in that situation, it happens. So she was in kind of another ward and she was moving, and they did sedate her. And effectively, from that situation, obviously with movement and perception and likelihood of falling, was dangerous. And she fell, and this is an issue we're in now. She's had a bleed on the brain because we're kind of debating whether that's sedation, because that's basically affected her mobility totally. She was walking perfectly before. Now she can't. So she's lost use in an arm and leg from a bleed. So I think weighing up, so that obviously if you're manic and it's a difficult situation,
it's getting the balance.
It's a balance, but I would say, beware of sedation.
Is it with the sedation? Did they end up taking it daily, or can you administer it ad hoc when they're having a delusion?
It can be what we call PRN, as needed. So we would do everything we can to divert that person's attention. So that's why life stories are so important, because the more we know about somebody, the more that we can connect with them. So, for example, when my aunt was in the home and she had dementia, if she got upset, I said to them, get her royal family books out, and she would start showing you she loved that, and she'd forget about whatever it was that was causing her distress. And so she didn't need any medication. But sometimes you get somebody that you just can't get them to settle.
Yeah, Mum's now definitely, she's got on her records that, if she needs it, the sedation is there, and if they start seeing patterns. But the other thing that we got, you made me laugh about your books, is we got Mum one of these dementia cats, because she had a cat at home. And the cat,
Dad's got one in his room.
It's just one of these battery operated horrible things.
I know, but do you know what my dad said? He went,
it's like Chucky.
I put one in his room because the home had one in his room already. And he went, he just said, "Oh, that's nice, but why do I want a plastic cat?" I was like, "Oh, okay."
It's that recognition, isn't it? Mum hasn't got that recognition anymore, but she seems to find actually just having that cat either sitting on her knee or by the side of her on the seat is really comforting to her. So
is it one of the big cats, Rachel? Is it the big cat that purrs and ears move? And...
moves and twists around.
Oh, okay. Oh, wow.
Yeah, they're
battery operated.
My dad's got one of the small ones that breathes. He's like, what do I want that for?
This is what we use.
Oh, wow.
That's the one. That's the one. Oh.
And they're absolutely brilliant. You know, there's a dog as well. I tell you what, we've been trying as well. It sounds like your people are not at that stage, but people later is I call it Cuddle Buddy.
Oh,
yeah, and it's got way. Well, right, Ellie, I thought exactly the same. I thought, I don't know about that, but I brought one. They're not cheap. They're £125 from the Alzheimer's Society. And they've got weighted arms and weighted legs. I thought it looked like an alien. So you can wrap it round someone. And inside,
I think my children quite like one of those.
Well, inside, what it's got inside is a little box. I can't do it now. Oh, here it is. A little box. And it's got, I don't know if you can hear, it's got a heartbeat.
Oh.
So it's got a heart. So it's got a heartbeat, which you can actually feel. It gets quite loud, but you can also download music, favorite music into it. So we've had people another lady with Charles Bonnet as well, and she cuddles it, and she strokes it, and it's that heartbeat, and she just spends her day like that, and it worked really well. It works really well.
It's really comforting.
Yeah, I mean, it's like empathy dolls. These, when we introduced these, I thought, I'm not sure, a bit Rosie and Jim. Yeah, right, but you know,
I'm not sure I could cope with that.
But they have been.
Not an Ollie doll, is it?
No, but they're so successful.
Oh,
And you get little girls, little boys, you get baby ones, but they are phenomenal, absolutely phenomenal. We used where are we? Reborn babies that are very realistic.
Oh.
Weighted. This one I've had for ages. It still smells like a baby. Very, very realistic. You know, you can't help it. If you're holding it, you start doing that. The only thing with the reborns is cold. And then some people think they're dead.
Oh dear.
So we've had to be sort of careful of these. And that's how really we moved to these. And I thought, well, they're not as bad as a Cabbage Patch. but honestly, they have been so successful. Especially this company. This company, J Jork, or whatever it's called. I can't never pronounce it. But these have been fantastic. They really have.
Aww.
Again, we're not looking at them through the eyes of somebody living with dementia.
Exactly. Yeah.
And the reason that I looked at introducing these, because team members, you know, in my previous role, would bring in the dollies that their children had grown out of and didn't want. And so you'd have tiny tears with the fringe cut, so it was stubble, felt tip pen all over the face. But you'd have somebody living with dementia walking around with this dolly. And I remember this son came in and he got so upset and he was fluctuating between sadness and anger because his mother was loving this dolly he thought was degrading and childlike. But also he said, my mum never cuddled me like that. And she's loving that lump of plastic more than me. And so that's why I thought about bringing the reborn babies in, these ones, because I thought, well, they might be a bit more acceptable, a bit more not childish. But then again, we had those incidences of people thinking they were dead. So we tried the other empathy dolls and they've been brilliant. Absolutely brilliant.
Yeah,
So
I would say, I mean, the cat has been absolutely fantastic for her.
Wow.
And she really finds just actually being able to stroke the cat and having it sitting there is, and other people within the home have also gone up and stroked the cat.
Oh,
So it's
yeah.
I've also noticed with her now that she's saying, you know, she's been a bit uncommunicative from the bleed, but she's slightly recovering from the bleed. But she's now, that empathy is coming out. So it's, how are you?
Yeah.
Which she hasn't said to us for, you know, ages, you know, that sort of situation. How are you actually, you know, and that empathy.
She's not been saying much at all.
She seems so much more level. It's quite surprising.
Even to the point where she was actually talking to us the other day and saying, I really like it here. It's a nice home. And I like the people. They're really kind. Yeah. So I think she's got that empathy back at the moment. And she's, you know, I think actually having that cat has really helped her sort of just settle a little bit. So
we all need something to connect to. And that's part of our personhood dementia care framework is the 7 domains of well-being, and that sense of being needed, having a purpose and being connected, a sense of belonging. And that's what we are trying to bring into the lives of people living in our homes. And so the more we know about a person, the more that we can support them. So life stories is so important. It really is. Like, I mean, there's a lady that I was talking to in one of the homes, and I think I was telling some of you that she's telling about her life on the fence. But dogs are a major part of her life. And so we would do work with her around dogs and bring dogs in to see her and ask her advice. Like, oh, well, you know, I'm having trouble with my dog. My dog's not doing this. How can I get it to do it? Then she feels needed. She feels like she's contributing. It enhances her own self-esteem. And even with her dementia, she hasn't forgotten what her work was and how to do it, you know. So it's that bringing us going into the person's reality, not trying to bring them into ours. And I love it because I have to be many different people many times a day. and I truly believe people living with dementia can't lie. I really believe that. They say it as they see it. You know? I remember one saying to me, do you want a sweet? And I went, no, thank you. She said, no, I'm not surprised. You're a bit fat. No, you better not have it.
It's definite honesty.
There's definite bluntness.
Oh, there it is.
The diplomacy switches on.
Oh, I remember one lady said to me, are you married? She was a headmistress. Used to be headmistress. Are you married? So I said, no, I'm not. So she said, oh, I'm not surprised. You're rather a plain Jane, aren't you? In fact, if I'd given birth to you, I'd have drowned you in a bucket of water. So when I'm training people that are new to it, I tell them stories and I say, don't take it to heart. Please don't take it to heart.
Oh dear.
I find the Facebook, Glenfield have got a great Facebook.
Oh,
and I try, when Sheila's at the home and she rings me every evening, I try to check Facebook before she rings me. Because you can bet your bottom dollar she'll say, I've been sat in the lounge and I haven't done anything and I haven't seen anybody.
And you can
I'll
see
say,
it.
oh, are you sure? did you not go into the foyer? Oh, yeah, but that was a load of singing, yeah. And I said, but hang on a minute, you'd got a smile on your face and you were shaking a rattle or you were doing whatever.
Yeah.
Or you had a little girl near your feet. Oh, yeah, she tickled my toes, you know, that was funny. But it's all that. And I sometimes wonder if with Sheila, she actually doesn't want me to think she's had a good time.
Yeah. It's a little bit of playing the guilt game.
Yeah. Yeah. And she has admitted to you, hasn't she?
Yeah.
My mum's a bit bloody minded, so she's with this stroke that she's had, the bleed on the brain. She'd lost the use in her right leg and her right arm. So I've just been telling her they don't think you can move your right arm. They think that's you need to show them you can do it. I know you can do it. You know, I know you'll show them.
Yeah.
And she's started to do it now. She's started to actually make movements to do it because she's determined to prove people wrong that she can do it. And she's it's a bit of reverse psychology going on there, I think.
Absolutely.
Yeah. But again, that can be put into care plans. If it's in the care plan, the team members can do it.
Yeah.
So that if anyone came in, like say CQC, and they heard the carers saying something like, go on then, prove them wrong, you can't do it, or something like that, it's acceptable because that's part of the care. You know, Betty's daughter said, we need to do this. Or Kathy said,
we need to put a few of those things in.
You know, when Sheila says she can't do it, tell her to raise her legs. You know?
Kick her up
so
the
with
bum,
these
I'd
care
like.
plans.
Sorry.
With these care plans, I should just be talking to them Ethelred about this, about what's in there at the minute and adding to that.
Yeah, absolutely. And each month you should be involved in evaluating.
I never am.
Yeah, so that's something we're looking at, but looking at the care plans and evaluating. Do you agree this is what we've planned? Anything that you want to add?
When's that meant to happen?
Every month. Every month we evaluate them.
Oh, okay.
And so we can always ask you, you know, do you think anything's changed? Anything you want to add to the care plan? Anything else? Kathy, seriously, if you need me to go and see Sheila at the weekend, I'm very happy to do it for you.
Okay, thank you.
All right, just give me a bell. Just get in contact with me and I'll do that.
Okay,
you need your break. You need your break.
My little grandson.
Can I just say it's lovely to meet you all.
So I don't know your name. I know Rachel. What's your name?
I'm John.
John and Rachel.
Yeah, easy.
Yeah. Yeah, it's the first one of these we've been to, and it's really nice to meet other people who don't do the same things.
Brilliant. Well, we do them every month. We do them every month. So we'll send out the invite to say what the next one's going to be about. But if you think of something you want, just email me or give me a call. We work around you guys. We're going to try and get some guest speakers. You know, we're going to get one of our regional trainers to talk about the training we do. I'll do a presentation on our personhood dementia care framework, what we're introducing, what that entails, and how we can work together. But if you think of anything that you would like, just let us know, because this is about what you want, not what we're going to deliver to you. It's about what you guys want.
Okay.
All right. Be great spending time with you guys tonight.
Nice to chat to you all.
As always, I'm always here for you, and I look forward to chatting with you next month. So have a lovely Easter.
Thank you.
Good night, everyone, and to you.
Thanks very
Good night.
much. Lovely to meet you. See you. Bye.